Just wait for those to find a seat. Thank you very much for coming out on I was going to say a cold and wet night, but it wasn't raining and it was 16 degrees according to my car's thermometer. But still, thanks for coming, even though our speaker was changed from a superstar to a local superstar. How did I deal with that? And my name is Leonard Isakowitz. I'm on the council. And before we get going, the usual preliminaries about exits. I think there's one at the back. There are no fire drills planned, so if you hear a fire alarm, it's for real. And I will now start talking about Graham Watt, who is our speaker for tonight. You may remember him if you've been coming here for a while. He is a council member, and he is Emeritus Professor of General Practice and Primary Care at the University of Glasgow. And he is admitted tonight to being a tuachta. For those who don't know what that is, he's originally from Aberdeen, and he completed medical school in Aberdeen, and then he went from the wilds of the northeast to the wilds of Glasgow, where he did his GP training in Townhead, which actually isn't as wild as it maybe once was. I've had to go there a few times recently. He established, he was interested not only in general practice, but he was and is interested in diseases and society and inequalities in medicine. And he established the Glasgow branch of an international multi-center study called the World Health Organization MONICA Project. He made Glasgow a center. And I suspect we were a good example, because this was monitoring cardiac problems, and we had lots of that. Glasgow was by far the best. Yeah, so it was, he doesn't miss an opportunity. So he gained further accreditation in public health, and then he worked as a research manager for the Chief Scottish Scientist's Office, and then he was a lecturer in public health. Now, when I was at medical school, public health was something that we call a Cinderella specialty. Somebody would get tucked away and they wouldn't do any particular good. They wouldn't do any harm either. But that's all changed now with COVID, AIDS before that, and other diseases. And people realize what a threat and how much good can be done from looking at not just individuals, but groups of individuals and populations and risk factors. So this is what he's been doing. He was appointed Norrie, if I'm pronounced that correctly, Professor of General Practice at University of Glasgow, and he has continued with his work since retirement. He also has other strings to his bow. He's the chairman of the Lancet Palestinian Health Alliance Steering Group, which he's been for many years. He's a trustee and board member of Medical Aid for Palestinians, a board member for Foundation of Family Medicine in Palestine. He's the chair of the advisory group on professions for the Royal Society of Edinburgh, and, by way of contrast, a board member and vice chair of the Scottish Professional Football League Trust. And he's been supportive of GPs working in deprived areas, and I think that's what the Deep End publication is about, being in at the deep end. And that was one of the reasons why he worked in Wales, and one of the reasons why he worked in Townhead. You were interested in deprived communities. So he's been, just one or two last things, he's been elected a Fellow of the Academy of Medical Sciences, which is a very prestigious, overarching academy in the UK. He was awarded a CBE in 2017 for his work, and he was also given a particular honour of, it's a Scottish honour to recognize and acknowledge and encourage people who have made a good contribution to society, but particularly in Scotland, and it's called the Saltire Society Fletcher of Saltoun Award for Science. So I think that's enough of an introduction from me. So without any more to say.
So I hope you can hear me at the back. I think so. Okay, well, now for something completely different. It's the second time I've been called to be a substitute in this program of lectures. So I'm always the bridesmaid, never the bride. But a pleasure to speak again to this audience, some of whom are younger than I am, to try and gain your interest. And what I've done is adapted a talk I gave to the Scottish Society for the History of Medicine earlier in this year, called Inequalities in Health in Scotland, a Search for Inclusion, much of which is autobiographical, but I hope you will see the reason for that. Now, in Fahrenheit 451, the science fiction novel by Ray Bradbury and feature film by Francois Truffaut, starring Julie Christie among others, and set in a future totalitarian state in which books were burned. You'll see the link already with this program of lectures. Fahrenheit 451 being the temperature at which paper burns. Our previous speaker didn't mention that, but he could have. Members of the resistance were each given the responsibility of memorizing a book. For example, Robert Louis Stevenson's Weir of Hermiston, to keep the stories alive, which is what I'm going to try and do this evening, keeping some stories alive. And in the words of Harry Gordon, the great Scottish musical hall entertainer from Aberdeen, lots of local stories that you maybe dinna ken. For the title of my inaugural lecture 30 years ago, I chose Include Me Out, Exclude You In. Include Me Out was a quote from Sam Goldwyn, the Hungarian Hollywood film producer who never quite mastered the English language. Exclude You In, I added myself. Inclusion and exclusion being themes that I've pursued throughout my career. And as a medical student in Aberdeen, and my imagination was fired by these words from Julian Tudor Hart, a GP in South Wales, writing in a career booklet for medical students in The Lancet. With great effort, any doctor can get to know all his patients, even in a city with high turnover. Only then can he learn to think of a responsibility not only to the patient sitting in the surgery, but to the whole population for whose care he's paid and for whose health he is responsible. He can then see his role as the ultimate custodian of the public health on a defined section of a world front against misery and disease. As a pioneer of what we now call population medicine, epidemiology was Julian's map and science his compass. Epidemiology is a study of whole populations, which can be done sitting at a desk, analysing routine data, or out in the community, collecting information from individuals. And as Julian said, sitting at a desk wears out the seat of your pants, collecting data de novo wears out the soles of your shoes. Shoe leather epidemiology has two challenges: to maximize the response and to characterize the people who are missing. And his science couldn't have been simpler, measuring what he'd done or hadn't done and being honest with the results. He was the first doctor in the world to measure the blood pressure of all his patients, pioneering then, orthodox now, the first to describe the inverse care law, that the availability of good medical care tends to vary inversely with the need for it in the population served. And he showed in a lifetime of clinical practice, working in a small, very deprived ex-mining community, how the inverse care law could be reversed. He was the only GP ever to get an honorary degree from the University of Glasgow. It's an interesting photo. Phil Cotton at the back became Principal and Vice Chancellor of the University of Kigali in Rwanda. Jill Morrison in the centre became Clerk of Senate, the senior academic post at Glasgow University, the only woman to gain that post in 300 years. Lisa Swartz on the left became Professor of Healthcare Ethics at McMaster in Ontario. Kate O'Donnell, inside left, is now Head of General Practice and Primary Care Research. So Julian was a big influence on all of us. And after qualifying and practicing in Cambridge and London, he joined the MRC Epidemiology Unit in South Wales with its pioneering epidemiological studies, with 90% response rates the rule. Contrast that with UK Biobank that was satisfied with a 5% response rate. The MRC had shown in a study of chest disease in a mining community that the first people to attend were men with occupational lung disease, hoping for evidence to claim compensation. The last to attend were those with occult tuberculosis. And in aiming for completeness, special effort is needed to include those who are most likely to be missing, excluded by the system or by themselves. The MRC's unit's high response rates were achieved by a research team of local people who knew their patch, the local folk, the leading lights, and how best to encourage people to take part. Their boss, Professor Archie Cochrane, shown here, not satisfied with a 95% response rate, asked for a list of those who hadn't taken part, whom he proceeded to visit, offering them a lift to the research clinic in his Daimler. He didn't recruit a single extra participant, because when you get down to the last 5%, those people don't take part in anything, never mind a Medical Research Council study. I saw this approach at first hand when I went to work with Julian and his wife Mary in the early 1980s. By that time, they'd stabilised the practice and had become the first general practice in the UK to get research funding from the MRC and the first to get a research grant from the British Heart Foundation, which is what I was involved in. And when I returned to work there as a MRC research register, we were interested in whether high salt caused high blood pressure. Having blood pressure data on a whole population, which he had, made it possible to identify families in which both the parents had high blood pressure or both had low blood pressure. And comparing the offspring of those families, high, high, and low, low, seemed a good basis for investigating whether some people were more sensitive to the effect of high salt intake on blood pressure. Here's Julian explaining the study to patients in the local primary school. Did young adults with a family history of high blood pressure consume more salt? The only way to find out was to measure their salt intake by collecting 24-hour urine samples. Not just once, but for 7 days in a row, because of the variability from day to day. And just imagine what that means in a deprived community, working underground, shopping with children, not being able to flush the toilet for a week. The response rate was 90%. Our laboratory was a converted ambulance garage, and the results showed that everyone was eating a lot of salt. No evidence of salt avidity, but didn't exclude the possibility that they might differ in their sensitivity to high salt intake. And that required an experiment in which everyone reduced their salt intake for 10 weeks, from 8 to 3 grams per day. A difficult thing to do, because most of the salt in your food is added not by you, but by the food industry. This poster and dish towel, printed at the Glasgow School of Art, gave a misleading impression in green of the number of foods people could eat. But they were helped by the provision of low-sodium bread baked by a local baker and low-sodium meals prepared by the research team. Whilst taking part in a double-blind randomized controlled trial of salt and placebo capsules, so that while everyone was reducing their sodium intake, half of them had it brought back up, taking the tablets. A wonderfully elegant study design. The research team comprised streetwise local people. We employed a cookery teacher rather than a dietitian. We didn't ask participants to do anything we hadn't done ourselves. 60 families took part, and we were able to compare blood pressures at high and low salt intakes in both groups, with no effect on their blood pressures. Not for the want of trying, perhaps not for trying long enough, but a phenomenal community achievement, probably unique, certainly in the UK, by a research team, not from academia, but recruited from the local community. Well, I got my MD from Aberdeen out of that, but the main thing I learned was nothing to do with blood pressure or salt intake. It was that in a community used to mining energy from fossil fuels underground, there was also huge resources of energy and goodwill at ground level, which could be mined for a social purpose, even in the most deprived community in West Glamorgan. So salt provided a metaphor. Sitting on your kitchen table, a compound combining a poisonous gas with a metal that explodes on contact with water. Think of all that energy locked away. Well, when in 1961 Julian was starting in Glencorrig, I was 9 years old in Aberdeen, watching the latest Hollywood epic El Cid, in which you may recall Charlton Heston plays an American in 11th century Spain. And what impressed me most was that up on the screen, being hugged by Sophia Loren, no less, admittedly playing her father, having just been killed by Charlton Heston, was someone who'd attended my school. This was Andrew Cruikshank, better known as Dr. Cameron in the original Dr. Finlay's casebook, with this rather striking introduction to his autobiography. I was born on Christmas Day 1907 in Aberdeen, and I'm therefore a Scotsman. John Buchan says that every Scotsman is a born metaphysician. All I know is that I'm not an Englishman. And in a somewhat similar way, I knew I didn't want to pursue my career in Wales, and not in England either. Marrying a Glasgow School of Art lecturer sealed the deal. A stepping stone back north was a 6-month community paediatric post in Edinburgh, split between sick kids and Ladywell Centre in Corstorphine. And rather than commute, I advertised myself in the Scotsman as what I thought was the ideal tenant, a professional person needing only 4 nights accommodation during the week. Which is how I found myself looking out over these views from a penthouse apartment in Queen Street, Edinburgh, looking north over the Firth of Forth. And I said I couldn't possibly afford this. I was asked what I could afford, and the deal was done. I asked my landlady what she did, and she said she was a statistician. She was Vera Carstairs, pioneer of desk-based epidemiology using census-based small area statistics, and an author of the classic text Deprivation and Health in Scotland, published in the early 1980s. Later on, finding it remaindered in a bookshop on Byres Road, I bought 30 copies for £1 each and distributed them to students. And the next move, as Leonard has hinted, was to a big epidemiological study, the Glasgow WHO Monica project, one of over 40 centres worldwide with the highest mortality rates in Glasgow, tracking heart attacks under 65 to see whether trends were due to changes in incidence or case fatality. No time to dwell on that. But I got that job in a 3-2 majority, and one of the 3 in my favour was the late George Forwell, Director of Public Health in Glasgow, who surprised me by sending me an article he'd written on population medicine, capturing the essence of what I had learned at Glencorrig, likening it to the artistic technique of pointillism. As a research assistant in Chicago, he'd been impressed by the work of George Seurat, the pioneer of pointillism, in which a picture is made up of multiple small points, each of which has a place in the big picture. I like this analogy, and also the idea that epidemiology is like putting on a pair of spectacles that allows you to see more widely and further ahead. For example, here's a picture of a brick. More bricks, part of a wall that's painted, something at the top, which turns out to be a hand as part of a mural with some attention-seeking children in the front. Then you begin to see where the mural is on the end of a house. As part of the Black Hill housing estate, no more, in one of the most deprived parts of Glasgow's East End. The sequence begs a question. What can you understand by studying the brick, the wall, the house, the area? Harry Burns liked these slides, and you may have seen him use them. Well, whilst studying coronary trends in Glasgow, for Glasgow Monica, I was struck by a 1956 article by a US physiologist called Hardin Jones, in which he wrote, "If the current trend towards lower death rates in adult life is to be seen in the United States to the same extent that it is already observed in the low death rate countries, it will not be apparent until about 1965, which is when the coronary epidemic in the US peaked." So I was intrigued by that and wanted to look at the prediction method, comparing the contrasting rates and trends in Glasgow and Edinburgh, big populations for which historical data were available, with a 4-year difference in life expectancy. So when employed in the Chief Scientist Office for a couple of years, I spent my lunchtimes walking the length of Princes Street to collect mortality data for Edinburgh City from the annual reports of the Medical Officer of Health in the library of Lothian Health Board. Something you could do then for free, which you'd have to pay for now. Here is St Andrew's House, where I worked, once described as a cross between a Tibetan monastery and a Kirkcaldy linoleum factory. So here are the resulting mortality rates at different ages in Glasgow and Edinburgh, from 1921 to 1981. Reducing slightly. Edinburgh on the right, Glasgow on the left. Sliding them together shows that rates were always lower in Edinburgh. But when you link these data another way, in cohorts according to the year of birth, another pattern appears in which differences in mortality in later life are part of a pattern of higher rates in Glasgow from at least early adulthood in successive cohorts for men on the left and women on the right. And we used these data to predict quite accurately what was going to happen in the 5 years based on the 91 census. Here are the data broken down to show similar trends from stroke, cancer, heart disease. Bottom right is other causes, because infectious disease in early life tends to hide this pattern. And what it shows is that the differences are not what you die of, it's when you die, how long you live. And in an article in the Health Bulletin, the House Journal of the Scottish Home and Health Department, we highlighted the data in that vertical box, which could be used to compare coronary mortality in middle-aged men in Edinburgh and Glasgow. But actually, it shows the partial understanding that would be gained by confining the study to that narrow box, when a much bigger pattern is there to be seen. At any age, Glaswegians have more miles on the clock, to use a motoring analogy. And a Guardian journalist asked to be introduced to typical citizens from both places to see if that was true. But of course, there are poor people in Edinburgh and rich people in Glasgow. It's the balance of rich and poor that is different. And the study showed the importance of early origins, beginning in childhood, long before it began to feature in health policy. This is the picture Brother and Sister by Joan Erdley in Aberdeen Art Gallery. It reminds me of my GP trainer at Townhead, recalling a home visit sitting in a dank sitting room in Royston Hill when he saw something unusual. A book. Asking if he could look, it was a book of pictures by Joan Erdley, a present to the Sansom family, saying thank you for their cooperation. But they weren't exactly pleased to be the flag bearers for childhood deprivation, saying there were neighbours in the street far more deprived than they were. To digress for a moment, back at Glasgow University, we were interested in lead in drinking water. And after all the efforts to remove lead piping and reduce plumbo solvency, the tendency for lead to leak out of the pipes into the water, was there still a problem? And we targeted the domestic water supply of young mothers in Glasgow, that is, the water they drank or used to make up bottle feeds, based on kettle samples, which is the standing water in the domestic kettle. It's a standard sampling technique. So mothers gave a blood sample and were given a small plastic universal container and asked to return it with a kettle sample in a jiffy bag addressed to the laboratory at Strathclyde Water. One participant lost the reply paid sticker and scrawled Strathclyde Water on the jiffy bag and put it in the post without a stamp. And in those days, a suspicious package containing liquid raised the alarm. The bomb squad were called in, and the sorting office closed down for an afternoon. Talk about research impact. The study showed lead levels in maternal blood lead and their domestic water supply that had reduced substantially, but 5% of bottle-fed infants might still be exposed to tap water levels above current guidelines. But I drew two other conclusions from this study. The one was that most people born or brought up in Glasgow prior to 1977, when water treatment was introduced, were exposed to lead concentrations in their drinking water 10 times the current limit set by WHO to protect children from intellectual damage. Think about that. Or perhaps if you were born in Glasgow before 1977, you can't. Second, how interesting to contrast the success of measures to reduce a chemical hazard to young children with the economic policies of the 1980s, Mrs. Thatcher, Nigel Lawson, tripling the prevalence of child poverty from 1986 onwards. It was as if the government was installing lead piping in the households of the poor. The Blair and Brown government reduced child poverty slightly, but as you must know, child poverty is still with us and has never returned to the low levels in the late 1970s. In the late 1980s, the Scottish Chief Scientist's Office retitled its Social Paediatric and Obstetric Research Unit at the University of Glasgow, calling it the Public Health Research Unit because maternal and child health was no longer an issue. Well, moving on, a great privilege at Glasgow was to chair the steering group of the Midspan studies. And in 2006, we celebrated 30 years. Stars of the show were Victor Hawthorne on the left and his young assistant, Charles Gillis, both now departed. It was a special thrill to see Victor back in Paisley Town Hall addressing a public meeting as he had done 30 years previously. He'd cut his teeth, his epidemiological teeth, with the mass screening for TB in George Square in the 1950s. One of his career highs as an infectious disease doctor was diagnosing TB in Coco, a giant chimpanzee in Bertram Mills' travelling circus. Perhaps some of you remember Bertram Mills' travelling circus. I certainly do. The Midspan studies were based in the boroughs of Renfrew and Paisley on Glasgow's southwest boundary, and to establish the eligible population, Victor carried out a local census using Boy Scouts. This theme of using local people. An earlier study comparing blood pressures in Tiree with places on the mainland, why blood pressures were higher in Tiree remained a mystery. A BBC film of that study was lost when the van carrying the tapes fell into Tiree Harbour. So that was the end of that. There were other studies with similar methods, not only the general population studies in Renfrew and Paisley, but also the collaborative study involving over 20 occupational groups in the west of Scotland. Victor recalled an inquiry from one of the groups consisting of procurators fiscal. Dear Professor Hawthorne, could you please explain for question 22 what is meant by the answer no? Midspan was a conventional cardiorespiratory screening study, not only of men aged 45 to 64, but also equal numbers of women, which was very unusual at the time, with an 80% response rate. He was another streetwise investigator using a team of local nurses. After 25 years of follow-up, we showed that, that Lady Paisley, a middle-class woman, had a 70% chance to survive to 70. A Paisley buddy, or working-class man, had only a 28% chance. It's not generally known that, that Geoffrey Rose from the London School of Hygiene piloted the Whitehall study of civil servants in the west of Scotland. And the similarity of methods made it possible many years later to compare, firstly, the occupational mortality of civil servants in London with workers in the west of Scotland, and also to compare workers in the west of Scotland with the general population of the west of Scotland. And I'm sorry that the figures are slightly out of joint, but what it shows is that the healthy worker effect meant that the collaborative study had, if you take Whitehall mortality as one, occupational mortality in the west of Scotland was 28% more. And if you took everything into account in terms of risk factors, the difference almost disappeared down to 0.97. I think the next slide shows the same thing. And if you compare in the middle the workers in the west of Scotland with 28% higher mortality than Whitehall civil servants, in the right-hand column, the Renfrew Paisley study was 66% higher than Whitehall civil servants. And again, if you go down to the bottom row and take into account all the confounders, the way in which they differ according to blood pressure and cholesterol and smoking and whatever, the gradients almost disappear. So in this cohort study, and it is a cohort study following people for a long period of time, there was no evidence of what's sometimes called the Glasgow effect, invoked sometimes on the basis of cross-sectional studies of routine data to explain the city's high mortality. But two midspan studies findings stood out: the importance of respiratory impairment as the strongest risk factor after smoking, and the underprediction of coronary events by the Framingham risk score. Respiratory impairment as measured by blowing hard into a tube, demonstrated iconically as Victor and Charles attempted to blow out the candles on the Midspan 30th birthday cake. There were three causes of reduced lung function. First, the long-term effects of impaired growth in childhood. Second, the adverse effects of active and passive smoking, because in a later study where we followed up 2,000 adult offspring of parents who'd taken part 25 years previously, lung function was lower in offspring whose mothers had smoked. So maternal smoking was casting a very long shadow. And thirdly, what industrial air pollution did to the outside of houses, it also did to the insides of lungs. And we still have air pollution, but from a different source. invisible as opposed to visible, the result of traffic on busy, high-sided roads. Applying the Framingham risk score to risk factors in people in Renfrew and Paisley showed this increasing number of events with increasing risk. And the following slide shows what actually happened in Renfrew and Paisley. Much higher levels because of the under-prediction of events in the west of Scotland by risk scores developed in other parts of the world. Suggesting that the risk score that all doctors get in the British National Formulae needs to be adjusted to take account of deprivation. And we were the first to present that at a conference, but Professor Tunstall-Pedo in Dundee was the first into print, repeating our analysis in the Scottish Heart Health Study, fast-tracking it into a cardiology journal. And it was a natural development because this work led to the development of the assigned score, now in routine practice, Scotland's alternative risk scoring system, adding your postcode to your coronary risk profile as a guide. And these are an outcome of the mid-span studies. Well, by the time that was happening, I had the good fortune to be appointed Nora Miller Professor of General Practice at Glasgow University. Here are colleagues at our old base in Woodside. 9 future professors in the group. Eventually, the department produced 23 new professors. One of whom, Matt Sutton, now at Manchester, led what we called the Platform Project, our attempt to establish a primary care observatory, similar to a public health observatory, collecting all the information relative to health in an area, but with one fundamental difference. Vera Carstairs, whom you remember, had pioneered small area statistics based on geographical areas, places that you would recognize, such as this slide showing in areas of Glasgow ranked by deprivation on the left and by health on the right. This was pioneering stuff in the 1980s. And when areas are socially homogeneous, like general practice populations in affluent Eastwood on the left, or the north of Glasgow deprived on the right, a geographical approach captures what there is to see. But when they're not homogeneous and are socially mixed, like the general practice populations shown here in the east of Glasgow, the red diamonds are the average and the bars are the range. The geographical approach misses important differences between and within practices. So we went on to divide the Scottish population into 10 groups. The second column shows about 500,000 in each group. And the third column shows the number of GPs in whole-time equivalents. And what the slide shows is that the number of GPs in whole-time equivalents is broadly flat across the distribution, especially in the most deprived deciles. And in terms of staffing, there's no need to dwell on that slide. In terms of staffing, it looks like a level playing field because everyone's head can be seen above water, but actually it's a swimming pool in which everyone's head can be seen, but GPs in the deep end are treading water, never touching the bottom. 10 years later, we divided the Scottish population again in tenths, affluent on the left, deprived on the right. And the lines show premature mortality in blue, premature morbidity in red, increasing 2.5-fold across the spectrum, whilst the funding per patient below in black is largely flat, especially in the deprived half of the population. It's a pattern, the inverse care law, if you like, that hasn't changed in the 10 years since this slide was made. In a study of 3,000 consultations in general practice, my colleague Stuart Mercer, now at Edinburgh, shown here getting married in a kimono outside the Lefroy distillery in Islay, as you do. Shows the consequences of the previous slide for patients and doctors. Consultations in deprived areas are typically shorter, despite higher levels of morbidity. Enablement is lower, especially for mental health problems, the commonest comorbidity. Outcomes at 12 months were lower, health literacy was lower, practitioners under greater stress. A subset of videoed consultations where you could actually see what was happening showed that for similar levels of multimorbidity, patients in affluent areas had 25% more time with the doctor. It's a recipe for preventable problems not being prevented, with predictable consequences for A&E departments and emergency wards. A similar study, now cited thousands of times, based on nearly 2 million patients in Scottish general practices, looked at multiple morbidity, the tendency to have more than one diagnosis. As you get older, as you know, the tendency to have 1, 2, 3 more diagnoses increases substantially. And if you have no diagnosis in your 80s, that's the blue group, you're either very lucky or you've not been counting. This slide shows the same data with a social gradient, multimorbidity always being higher in deprived areas and starting 10 to 15 years earlier in the most deprived 15% of the population. And this slide, if you can bear with it, each bar is a common diagnosis, heart disease, stroke, diabetes, that keeps the health service busy. And in each row, the first figure on the left is the percentage of patients with that diagnosis who only have that diagnosis. And they're always a minority, with the exception of asthma, which is different because it affects kids. Most people have other conditions. But most studies of single conditions exclude complicated people with multiple morbidity. Much of the research literature informing what is called evidence-based medicine is a monument to this source of bias. Remember that patients with 4 or more conditions keep the NHS busy, accounting for 1/3 of unplanned emergency admissions to the hospital, a half of potentially preventable emergency admissions. Here's a slide based on the same data, the diagnosis on the left-hand side, and the blue circles are just a reflection of the proportion of patients with each diagnosis which have other diagnoses. And what the slide shows, take my word for it, is that between 1/4 and 1/5 of patients are on antidepressants or analgesics for chronic pain. And they need professionals capable of seeing the whole picture, not just the one diagnosis, but all of them. My colleague, Stuart Mercer and Bridie Fitzpatrick, carried out a study called the Care Plus study, an exploratory randomized controlled trial of longer consultations for complex patients, plus support for GPs and patients. But what is a complex patient? Some people with lots of conditions aren't complex. You may be in that category. Well, some patients with single conditions are very complex. An unknowing researcher would take a long time to find that out. After failing to find a working definition of complexity, a patient in this study was considered complex if their GP thought so, drawing on their knowledge and experience of the patient. And when patients identified in this way were characterized later on, they were certainly complex in terms of the numbers of conditions, but assessing their complexity wasn't the starting point. And funding bodies don't like this. They want to know precisely who you're going to study and why, insisting on time being spent to characterize participants beforehand, something that is unworkable as a proposition in general practice in deprived areas. And so research on such patients is excluded, even though they keep the health service busy. In the rare opportunity provided by the Care Plus study, I think entirely due to the streetwise nature of the research nurse in charge, longer consultations not only improved the quality of life on the left after longer consultations, it also prevented the decline in the quality of life seen in the control group. An intervention found to be cost-effective by conventional criteria, but hasn't found its way into health policy. It's not a drug. In deprived areas, mental health problems are the commonest comorbidity for 3 reasons. First, as this slide shows, as the number of diagnoses increases, so does the prevalence of depression and treatment with antidepressants. You can understand why that might be so. Second, there are the long-term consequences of adverse childhoods, which are more prevalent in deprived areas, typically affecting the ability to develop relationships with friends, family, professionals, and authority. And third, of course, people are living hard lives, struggling to make ends meet. They don't have a deficiency of Prozac or similar drugs in their blood, but that's often what's on offer. I mentioned the Deep End project, and so has Leonard. Based on the 100 most deprived general practices in Scotland, originally identified in the platform study as I showed earlier. And we started with a conference at Erskine in 2009, the first time that group had ever been convened or consulted. Previously, they'd been excluded. And now the Scottish project is one of 20 Deep End projects in 9 countries and 4 continents, all based on frontline practitioners like Tutor Hart, committed to improving health in deprived communities. When I last spoke here, we had 12 Deep End projects. Now there are 20. And here are the logos of the 2 most recent. Canada on the left, you can see a forest with a bear, and Frankston in Australia, just outside Melbourne, on the right. One of our successes has been the rollout of link workers, a new type of health professional capable of signposting patients to relevant services and resources in their community, but mainly with the time to sit down, tune in, find out what the problems are, and work out a plan and accompany the patient on the journey, helping people bewildered and daunted by the fragmented nature of our health and social care system. Small wonder that the formal evaluation of link workers showed benefits to mental health, which you would expect if somebody pays attention to you and interest. As in another study from those 3,000 GP consultations showed, patients could report that they found the doctor empathetic without being enabled by the consultation, but they never reported enablement after seeing doctors who are not empathetic. If the doctor's not tuning in, caring what happens, anything else they do will be less effective. As you may have seen in the local papers, there was a fuss recently about who would pay for the continuation of link workers. Neither the government nor the local NHS wanted to pay. Eventually, after a campaign, involving link workers, patients, GPs, journalists, local politicians, the government came up with new funding, but still fixed-term funding. And if there's one thing we've learnt from all this, researching and addressing health inequalities, you only get to play at Little Hampden. You don't get to play in the main stadium where the big players and the big resources are at stake. We've learnt that while research evidence on health inequalities is necessary, and in some respects Scotland is a world leader, it's not sufficient to make change happen. In the last 2 decades, Sir Michael Marmot has probably been the best informed, the most persistent, and the clearest advocate of policies to address health inequalities. Sir Harry Burns, the equivalent in Scotland, to no great effect. It reminds me of this poster. They told me to smile. It could be worse. I did smile. It got worse. The other thing that's useful with the Hampden analogy is the distinction between being on the field and being in the stand watching. So many researchers on health inequalities are observers from the stand. And that's a very weak position to be in trying to affect change. You need to be on the field. At the first meeting of the Scottish Deep End Project, we resolved not to produce another report on health inequalities to be discovered by the local media every 6 months or so. Plenty of reports of that nature already. Of course, the causes of inequalities in health and the measures needed to address them go far beyond what can be achieved by general practice. But with a population approach, as Tudor Hart showed, it can make a contribution. Unlike most commentators on health inequalities, GPs and their primary care colleagues can make a difference to patients' lives with longer consultations, link workers, financial advisors, other co-workers embedded in the practice, not just working nearby. And in doing so, I think they make what is a more important contribution as flag bearers for the principle that everybody matters, an inclusive principle that was enshrined in the post-World War II consensus, which most of us have enjoyed in our careers, our education and our pensions, which has been weakened by divide and rule politics with its playbook of demonizing others, whether they're people on benefits, asylum seekers, immigrants, the EU, etc. As Oscar Wilde said, the smallest act of kindness is worth more than the grandest intention. As William Blake said, he who would do good to one another must do so in minute particulars. The general good is the plea of the hypocrite, the flatterer, and the scoundrel. Well, I'm glad to say that the Deep End movement, well, that's now what it is, beginning in Glasgow and Scotland, but now spreading internationally, working to improve health and narrow social division, is grounded in small acts of kindness, in minute particulars. Last April, in this very room, we had the most recent Deep End conference, and here on the steps on the bottom right are the movers and shakers of 12 of the projects. A meeting fueled by passion, energy and positivity, unlike much of the world outside, but harking back to that example in South Wales, the passion, the energy and the positivity is there if you know how to mine it. In their book, Solidarity, the Past, Present and Future of a World-Changing Idea, Taylor and Hunt Hendricks describe organizing as a kind of alchemy. It turns alienation into connection, despair into dedication, and oppression into strength. Solidarity has been and is an important achievement, connecting otherwise isolated colleagues with similar values and aspirations. As we say, by excluding exclusions, by including people, and building relationships, inclusive healthcare remains a civilizing force in an increasingly dangerous, fragmented and uncertain world, and must increasingly be fought for. But for now, that's the end of my journey, and I've told you how I got there. Thank you.
So, thank you very much, Graham. And we're going to have a short break now if anybody needs to escape, either for a comfort break or for an escape. and then we'll rejoin in just a few minutes. Is this microphone working enough? Can you hear me? I think so. But thank you very much, Graham. And are there any questions? We've got 2 roving microphones here. Now, if you have a question to ask, please raise your hand. And when you do, the microphone will come to you. And as you can see, this is how it works best.
That chap up there.
Thanks, Graham. Ian Smith, you know me. And at my retiral I read out at the end Tom Leonard's poem, The Liaison Coordinator. And our great Glaswegian or Paisley poet was very sceptical in that poem of some outside middle-class figure descending on a poor community to try and help abolish the ills. But it did seem in your talk you're saying that link workers work. I've always felt it needs to be a grassroots up thing rather than something descending from above to the people need to want it. You know, my socialist upbringing would tell me.
I think you're referring to Tom Leonard, is that right? To Tom Leonard?
Sorry, say again?
Are you referring to a poem by Tom Leonard?
Yeah, the liaison coordinator,
Coordinator.
which is incredibly sceptical about someone with a degree in F knows what coming to help the poor improve their lot.
It's a wonderful poem in Glasgow vernacular. One of the highlights of my life, actually, was having tea with Tom Leonard. He'd been in an audience in this room, actually, where I was hosting a Palestinian colleague who was giving a lecture. And Tom Leonard was in the audience, and this was 10 years later that he told me about it. And what impressed me was that somebody who was obviously pro-Palestinian was wearing a suit and a tie, which he thought was unusual. So we talked quite a long time about Palestine, and he gave me a copy of a poem he wrote called "Being Human." I don't know whether you know it, but it's about it's become more and more relevant, that poem, in terms of the responsibility of citizens to humanity and he had 4 copies of them, and he gave me one of them, and it's an absolute treasure, which I must pass on to somebody else at some point. But your point and his point is absolutely on the button. And in a sense, it's illustrated by, I think I've given lots of examples in that talk of where employing local people with local knowledge has been the key to things happening. Otherwise, you're starting at an enormous disadvantage of ignorance. It's a bit like seeing a doctor for the first time and he knows nothing about you. Compare that with seeing somebody that you've seen several times, and so much can be taken for granted at the outset, and the exchange takes place at a completely higher level. And I think what Tom Leonard was getting at was people who were at least one step removed from that local knowledge and connections. There's a bit of an industry about that. You know, when I'm trying to annoy colleagues in public health, I point out that people with public health in their job title often have very little contact with the public. Whereas people who do have contact with the public tend not to think about public health. And often people talk as though there's a natural alliance between these two categories, but actually they're quite a long way apart from where they start. Yes, that's one of Tom Leonard's wonderful.
It's a wonderful poem.
Best heard rather than read.
Yeah, you need to get your eye in for the yeah. Anyway, thanks, Graham.
Any other questions? Tony?
Thank you. Is there any measurable effect on population health of the GP contract of the Blair-Brown years?
Well, my colleague Stuart Mercer, whom I mentioned, had the contract to evaluate the most recent GP contract, the Scottish GP contract. And his conclusion was that it had been really incompletely explored in terms of its possibilities. And he didn't say it was a dead duck, but it was still pregnant with possibility rather than having delivered what it was supposed to deliver. So, I mean, we spent a long time, wasted a lot of the time trying to influence the contractual terms under which GPs work. Because they're paid capitation by type of patient, by the age of the patient, whether they see them or not, which is a good arrangement, plus various item for service fees, and some, there used to be quality rewards. But the GP contract does two things. It's a way of paying GPs, and it's a way of supporting services. And obviously there's a contradiction, a corruption within that, because it's serving two completely different purposes. They overlap, but they don't coincide. And if you try and alter something that affects how people are paid, you have to expect resistance, understandably. So that's why I mean, the reason we got into that was because when that slide that I showed you with the blue and the red and the black lines was published, Murdo Fraser, amazingly, it was Murdo Fraser, the Tory MP for Fife, or Kirkcaldy, asked the First Minister, Nicola Sturgeon, what she was going to do about it. And she said, about the inverse care law in Scotland, she said it would be dealt with by the contract. And that was because she didn't know any better. And it certainly wasn't dealt with by the contract. And that's why we've subsequently tried to get resources into general practice in deprived areas through other means. The contract is too hot a potato, really, to try and get progressive policies through it.
Thank you, Graham. If you had, say, been Nicola Sturgeon those years ago, or if you, say, were John Swinney now, how would you change things in your ideal world? Because I'd be there to support you.
Yeah. I would, well, there's no point in imagining, manna descending from heaven and having the luxury of being able to decide how to spend it. Possibly we had that opportunity with North Sea oil, but it wasn't taken. So plans have to be realistic to some extent. I think there's a dearth of evidence linking the under-resourcing of general practice in deprived areas relative to need and the consequences for the health service in terms of the pressure that puts on A&E and hospital emergency services due to preventable things not being prevented. And that would provide managers and politicians with an argument that they were very familiar and comfortable with, because it would be seen as being efficient, not necessarily, not just equitable. So that's a gap I think needs to be addressed. The deep end is, it survived 15 years in Scotland, and it now has a foot in the door. The chair of the steering group is actually a part-time civil servant in the Scottish office, and that's because the Scottish office wanted that to happen. So, although it takes a long time, we've not only got into the vocabulary, we've got into the discourse, and things are happening slowly. But it's difficult at a time when the whole system is under pressure. I think in the one thing I think I would like to see happen is for the government to fund what we call the Pioneer Programme, which is put young GPs into deprived practices. It gave them experience of those practices. It released the time of the host GPs who knew best what needed to be done but hadn't the time to do it. It kept some of those GPs in practice instead of retiring because they got a charge of energy from the opportunity and from the exposure to younger doctors. And most of the younger GPs who had that experience have stayed working in those areas. So the irony is that that scheme has been copied in England by a scheme called the Trailblazing Scheme. So we've had a much bigger effect on that in England that we have had in Scotland, although the Scotland scheme was based on another scheme in North Dublin, which just shows the advantage of the networking and how you can transfer learning from one place to another.
Can I just, I don't know if this is working or if this one's working, but can I just ask you, if resources were infinite and medical services were infinite, do you honestly think that that would solve these great problems?
No. Because they're deeply rooted in healthcare is picking up the pieces mainly, apart from investment in maternal and child health, which is long-term benefits and consequences. But it's a demonstration of the importance of inclusion. I think that's what I think the NHS stands for, is that everybody's on the same boat. I mean, I'm going way beyond my area of any authority, but my understanding is that we're all living in a world where there's increasing competition for the resources that are being squandered within the world. And is the solution to that going to be divide and rule, with the strongest winning and the poorest losing? Are we going to put up barriers to people who are fleeing countries where it's impossible to live anymore? Or are we going to be welcoming? Of course, that opens up a whole can of worms in terms of the historical legacy of a relationship with other countries. But I think it's part of a big debate on inclusion or exclusion. And it mustn't just be an abstract debate. It has to have expression in things that we do. And the healthcare system in this country is, beyond any measure of doubt, the best example we have of that expression of values, and needs to be protected and supported.
Any more questions? I'm just going to, there are a couple there. I'm just going to say, I'd like to recommend an author that I've grown to dislike, but he wrote a book called Hillbilly Elegy, and he's Donald Trump's running mate. And he came from a very deprived area, and he wrote this wonderful book on what he had to face coming from the poor so-called white trash of America, and how he got around that.
But I think you're not well regarded by people who live in those areas.
Oh no, well, I'm saying, but it was a most interesting idea of the complexity, the most idea of the complexity of being in an underclass. So whether it was accurate or not. Anyway, he's now a traitor to the cause, having signed up to the Donald and all the rest of it.
Because one thing I wasn't expecting was a discussion about J.D. Vance. And hopefully after November the 6th, we won't have to discuss him anymore.
Sorry, there was a question there. Fiona?
Yes.
Shona.
Most of you talked to us, and the statistics that you've been showing us, right, do very clearly show that the main risk to your health and to your longevity is undoubtedly poverty. And that has been established by, hard statistics and research. But what seems to have come out of it, from what you're telling us here and what is on the screen at the moment, the statement that's there, I won't read it out because everyone can read it, but it's a bit of a mission statement. And I'm just a bit concerned that that's where certainly experts in the field like you should have reached, that that's what you have to do in order to influence things. whereas most of us think, or hope optimistically, that objectively our governments are taking account of these statistics in their decisions about the allocation of resources and what is most effective in the allocation of resources. But I think there is an underlying issue here about your faith in general practice. I'm not sure it's entirely shared by most of us sitting here, certainly at the present moment, when most GP practice consultations, far from being extended in poor communities, appear to be taking place on the telephone. And when the main complaint is about access to GPs at all, and where the kind of solutions that seem to be proposed for the future are likely to be things like AI, and where West Streeting down south is talking about completely changing the independent business status of GPs as practitioners who control their own destiny and employing them in some form or other directly so as they begin instructed what to do. So perhaps you'd like to tell us what you think about all these things.
Can I just ask you to give us the essence of the question, please?
The essence is the future of general practice.
Okay, thank you.
I don't disagree with your comments about general practice, and I've not been talking about general practice as a whole. I've been talking about as a minority aspect of it. If you had been in this hall back in April when we had the deep end from different countries, you'd have been impressed by the positivity in the room, completely at odds to general discussions about the future of general practice for various reasons. One of which is that whilst there's been a 50% increase in the consultant establishment in Scotland in the last 20 years, general practice has largely stayed the same. That's unbalanced the health service. And it needs to be, so most GPs are now working in an unbalanced situation where they have increased workloads, less time, and they're behaving, as most people do, as they see best fit in the circumstances they find themselves. So I'm much more sanguine about the deep end GPs than I am about general practice as a whole. But in a sense, the deep end, I think, is a resistance movement in bad times. And resistant movements are how people connect and work together for better times in the future. And I think insofar as they are keeping alive, as best they can, ideas of holism and continuity and multidisciplinarity, which are not specific to the deep end, but they're being led by GPs who have a passion for it, and therefore they have energy that perhaps others don't. I think that's one has to look around for positive things on the landscape, and that is one of them.
Thanks. Any other questions? There's a man with his hand up there, the orange shirt. Behind you, Con.
The orange shirt. This is working. Question I guess I have, besides pending my need to you, who puts up with two brick walls, the Palestinians and Scottish Health. What is your thoughts about specialist GPs? Should there be specialist GPs so that if I walk in and say, I've got a mental health problem, that I'm not having to, they could be referred to somebody in their own practice who has expertise in that, as opposed to a GP who may have some expertise, but is actually having to deal with also my heart condition, all of these other things at the same time. Should it not be, for example, it would be possibly more important for the older, the more established GPs to be moved up as a specialist GP within the practice, and have the new ones coming in being the generalist, in which you're not wasting the talents.
Are you referring to the current situation where many GPs are generalists with a subspecialty interest, Or do you think they should be just subspecialists? Was that your question?
You have the general GP, but within the practice, that if somebody's coming in and you know that they come in because of cardiac issues, they're not taking the time. They have it, they can answer the questions more quickly. They can almost not being consultants, but being almost an in-between stage. So you have the link workers, hopefully.
Okay.
But you also have somebody who, as a GP, has more expertise in dealing with the link workers in that specific
Thanks
field.
very much.
I think my instinct is not to formalize that with sort of neat job descriptions and rules and to which people must fit. I think generalism, being able to respond unconditionally to whatever a patient presents is a very important aspect of the front line of the health service. Continuity is also important because then you build up a shared memory and a shared understanding, which allows you to achieve more in serial consultations, not necessarily in a single one. There is that specialization in the sense that you describe, but I don't think it's specialization in terms of being an expert in a particular disease or area. I think it's it's a nous and wisdom that comes with knowing patients in a place for a long period of time and being able to manage uncertainty, which is what we're often having to cope with, in a way that one of the if you put nurse practitioners into the front line of the health service, they're good for some things, but they tend to be risk averse, which means that they'll investigate more and they'll refer more. So the health service will actually incur additional costs because of that type of person in the front line. There's a famous body of work by a US Dr. Barbara Starfield, published in the 80s and 90s, comparing health systems around the world in terms of their efficiency and their equity. And the most equitable and most efficient health systems, achieving more with less, have been those with a strong front line of the service without direct access to specialists. And this is not because of the brilliance of frontline doctors or quality initiatives. It predates all of that. I think it's because if the front line of the health service is manned or womaned by pragmatic, conscientious people on the patient's side, on general, it keeps the balance of care between the community and hospital on the right side of things. Of course, in any system, there are always positive and negative effects at the edge of it. But in general, I think the reason why the NHS compared so well with other systems when the New York-based Commonwealth Fund compared the 12 most affluent healthcare systems 10 years ago, and the NHS came top. 10 years later, it was fifth because it had dropped. That was despite having less money spent on healthcare in this country from every other country, I think, apart from New Zealand. I think the reason for that was in large measure because of the structural aspect of the health service in terms of the balance of frontline and secondary care, which we've somewhat lost in the last decade. And I'm not sure, I think your idea of specialism within general practice, I feel very uneasy about that. I feel particularly uneasy about the idea that only experienced doctors should see complex patients, and that's all they should see, because that's a recipe for burnout. As night follows day. If all you ever see are very complicated patients, 20 in a day, how long are going to people stay in that line of work? You need to mix it up. And I remember Chris Johnson, the GP in Paisley, regretted the loss of ear syringing. It was taken over by nurses. And there was an efficiency argument to that. But he liked doing it because it was very hands-on, very practical, with a brilliant result in almost every case. And in a sense, it lightened up his day, so he was better off to go and see the next patient. And that's the way I've always felt that within the particular conditions of generalist practice, there's a kind of an economy that's being managed, if not explicitly, then implicitly, by the decisions that are taken at all sorts of different levels. And when you get a health economist coming along to try and rationalize the system, they don't understand that microeconomy of practice and the activity. So you get people like McKinsey coming along, trying to understand general practice as if it was a business. Which it is.
Can I just intrude briefly and ask what you think of optometrists dealing with all eye problems, whereas GPs used to? But nowadays, there's a sign at my GP and most other GPs as saying, if you've got an eye problem, contact your optometrist. And I say this as a consultant ophthalmologist, retired.
I think that's a very good idea.
But that's specializing.
Yes, but that's not an argument for specialism across the board.
No, I'm not saying, I'm just using an example.
Yes. Oh, well,
To say it's not a black and white, like most things, it's not black and white.
I'm not arguing for any golden rule that applies in all cases.
I know. Behind you, Colin.
Thank you. I'm wondering if you have thoughts on the number of trained medical personnel who are currently leaving for Australia and New Zealand.
Yeah, a lot are, and a disappointing amount are actually leaving the profession. I have a colleague whose views I respect, who thinks it's largely a temporary phenomenon, and that many of these doctors will come back after a period in Australia and New Zealand. I think that they get paid more, but the cost of living is more, so the financial advantage isn't that great. The weather is better. But I think it's a problem of manpower planning, which is just not one of numbers. It's a question of people finding themselves in jobs and career tracks that they're energized by, to feel positive about their work. I mean, the determinants of professional satisfaction, according to a chap called Daniel Pink, are autonomy, some control over your work, mastery, being good at what you do and being valued for what you do, and the third thing is purpose, in the sense of working towards some shared goal with others, being part of something bigger than yourself. And if you get all those three things together, then you're more likely to be working in a job that energizes you and doesn't drain you. And therefore you have this source of additional energy and resource. And I think, and this is just a personal opinion with no authority behind it, that the experience of young medical graduates going into F1 and F2 jobs in hospital, which aren't like what, when I graduated, you went into a firm of senior doctors and younger doctors who looked after each other in one place. And now people are working in shift systems that are very impersonal, exhausting. When I qualified, you could be on call for quite a long period of time, but not very busy, which made it feasible to be on call for a long period of time. But now if you're on call, you're meant to be busy the whole time. which means you're exhausted about it. So I think there are lots of reasons why people might vote with their feet at that early stage of their career.
Where's Colin? Colin? Is there just one microphone? Has your microphone died? I can take this.
Hello, thank you. I have a question about smoking. Smoking, just see you have some research about smoking, but I think now it's the vaping. I just noticed vaping is all organic, and there is where maybe low smoke, low smell, but I can feel in the inside or just people vape, then all the surroundings organic. Is it these organic chemicals affect the health? But actually, I don't want to vape, but I forced to vape because I go inside the indoor people vape. But we don't know. They low smoke and low smell. How to control, how your doctor...
Could you just summarize that? I'm sorry, I couldn't quite...
You don't know. Just vaping, smoking.
Smoking and vaping.
Vaping now, maybe low smoke and low smell.
Yeah.
They vape inside, then...
Right, so are you talking about the hazard of vaping?
Yes.
Okay.
But
thank you.
yeah, I don't care, but I don't want. They vape, but they inside all surroundings.
Okay.
Organic.
Thank you. I don't have any knowledge about this.
When I was involved in this research, vaping hadn't been invented. But it seems to be an addictive habit through the nicotine. And it has huge... Of course, if you walk along Dumbarton Road, the number of vaping shops is just, overtaking pubs and betting shops and charity shops.
There are reports of children vaping more than smoking.
Yeah.
Children, non-smokers.
Also in university.
In university too. Well, they're children too. Anyway, thank you. Any more?
It's interesting that most of the questions are in areas beyond my expertise as a long-time retired
Can I ask you a last question and end with a bang?
Sorry?
End with a bang. End with a bang,
Oh, yes,
rather
okay.
than a whimper.
Yeah.
You said you were an expert, you were associated with knowledge about football.
Yeah.
What's the risk to the young population, this is an epidemiological question, to the youngsters of heading the ball and getting early dementia?
Yeah. I think that's going back to my medical student days, I think that's a question that you get at the end of the oral when they're working out whether you deserve a distinction or not.
Exactly.
So, I mean, it's a Glasgow researcher who's done the work on head injury. I think that they do ban head injuries in school football now. And I don't know what effect it has on the rest of the game. I mean, I'm a season ticket holder at Partick Thistle, and they are. It's very, they seem to specialise in the long ball, and the long ball means hoofing it from one end of the pitch to the other. And when it gets to the other end, somebody heads it, and the ball has been up in the air and it comes down and it hits somebody's head. And it's like watching a boxing match when somebody gets a punch on their head and you think, gosh, what's happening to the brain inside that skull? You hope that it's being hit head on and not rotating. But even if it's head on, your very fragile brain, which is the source of all consciousness, memory, emotion, thinking, personality, is being shuggled around inside. So it gives me the heebie-jeebies to see people being boxed on the head. But in a sense, rugby is ahead of football because it is struggling so much with the same issue.
Anyway,
And,
I think
I think the basic argument is that you can't look to sporting authorities for progressive policies. They are, by instinct, they are conservative with a small c, and therefore they tend to lag behind what's needed.
anyway, I've stirred the pot enough, but
Sorry?
anyway, we're out of time. We're out of time, so we can continue the discussion.
That's another lecture, actually.
Anyway, thank you all for coming. Thank you very much for a very interesting talk. And next talk in 2 weeks' time. And please join us for a drink of something with alcohol or without. And safe home.